good evening to all. I think this is a class after a long break of around 2 years to me, because I think I have been a faculty member for almost all teaching entrance academies across India. But I think the last 2 years there was nothing, and I'm very happy to be back again with all of you. And I am directly going into the class because I don't want to talk anything more on because we have very, very limited time. And I have an order 500 odd questions, nearly 500 questions. These questions were originally framed to address around 2,000 entrance questions which had been asked in the various entrance examinations in the country, primarily for aims. Okay, but in a very limited time of nearly 1.5 hours, I don't think we will be able to go into each details of these 200 entrance MCQs. 2000 MCQs that I have designed to incorporate in these 400, 450 or 500 questions. But till then, still we will have a discussion on, I will go to maximum number of these questions, because I'll try to go to maximum number of these questions. You know, in every entrance examination, 20% the questions will be repeated, and that is for sure. And the questions will keep on coming from the same areas and same areas of the textbook, not from the first page to last page of Harrison. It is nothing like that. Questions will keep on coming from the very same areas of the question of the textbook. And moreover, question setters given instructions as I have had the luck to be associated with the question pool questions of the various entrance examinations. I can tell you the instructions given will be like this question should come from these areas. So that is that means there is some these areas. And so I can tell you an example. You will not see any entrance examination question in ophthalmology without having a question on retinoblastoma. So this gives you the clue that you have to repeatedly go back and refer the areas from where the questions had come, because that areas are the question prone areas. So I will be directly looking into these questions. I probably will not be discussing too much on any question, because my intention is to discuss 10 or more MCQs from each of these questions, but this is practically not possible in this time. And so I will be looking straight into only these questions and try to answer these questions. And these questions will give you a refresh or a review of whatever you have learned. And I am sure that you will not be able to get much benefit from these 1.5 hours. You cannot comprehensively cover the topic, but you can just look at this question. This will give you just a revision. And you can contact me in anytime, with any questions on my mail ID, so that I will be able to answer any of your queries till your exam. So with that, I can just look into the first question, which is not true regarding hypertension and eye. You probably have heard about hypertensive retinopathy. You probably must have heard of all these, which is not true regarding hypertension in the eye. Can produce superficial retinal hemorrhage? Yes, it can produce superficial retinal hemorrhages. It can produce hard can it produce hard exudate? Can it produce soft exudate? Cannot produce disc edema. Yes, it can produce any type of exudate, hard or soft exudate, but it can also produce disc edema. That is again is another entrance question. Hypertensive retinopathy with disc edema is called a stage 4 hypertensive retinopathy, or the malignant hypertension. It's very important MCQ, malignant hypertension or stage 4 retinopathy, hypertensive retinopathy where there is disc edema. So the answer to this question is D. So this hypertension when there is disc edema is also called accelerated hypertension or a malignant hypertension. Okay, these are some of the pictures of these. You can see there is a macula. You can see the hard exudate arranged like a macular star or a macular fan pattern. Soft exudate. Soft means as they are otherwise called a cotton wool exudate, and even you can see disc edema where the margins of the disc are not clear. So this is a stage 4 hypertensive retinopathy where there is disc edema. So there is disc edema in stage 4 hypertensive retinopathy. See, you can look at this very, very common question that you've been repeatedly asked by various entrance question setters. Hypertensive retinopathy's classification is called the Keith-Wagner-Barker classification. This entrance question is one of the most commonly repeated entrance examination question for various entrance examinations. All other choices had been entrance examination questions, but I think because of lack of time, we will not go into each of these, but I will just look into the C choice, that is McCollum's classification. Again, a common entrance question. This is the classification of trachoma. I think you have to little fast take down these answers, whatever I say, because we cannot wait for a lot of time. So McCollum's classification is for trachoma. This is a rhyming word for McCollum is trachoma, and Rees-Ellisworth classification. Another very common entrance question. Rees-Ellisworth classification is for Rees, R for R, that is for retinoblastoma. McCollum, the rhyming word for trachoma, while Keith Wagner Barker classification is the classification of hypertensive retinopathy, while Earlyhouse classification, another entrance examination question, is for diabetic retinopathy. Very rarely, this is an outdated classification, but occasionally this question has been asked as entrance question. So Keith Wagner for hypertension, McCollum for trachoma, Rees-Ellisworth is for retinoblastoma. So which is not a feature of hypertensive retinopathy? Salus sign, Gunn sign, Bonnet sign, Elschnig or Seegrid spot. Salus sign and Gunn sign are AB crossing, arteriovenous crossing signs. So they are signs. Elschnig spot is actually a choroidal infarction, which is seen in hypertension. So again, that is a hypertensive retinopathy finding. Bonnet sign per se is not a sign of hypertensive retinopathy, but is a sign of venous occlusion. Is called pre-thrombotic sign of Bonnet. So some textbooks it's written Bonnet sign as a sign of hypertension. It is not true. It's a sign of venous occlusion, vein occlusion in the retina. But Salus sign, Gunn sign, and Elschnig spot are signs of hypertensive retinopathy. So don't get confused by reading some textbooks. So Bonnet sign is not a sign of hypertensive retinopathy. So which is not true regarding malignant hypertension. When BP goes above 140 millimeters of Hg, dyskidema develops rapidly. We don't know. Dyskidema is a feature of malignant bar accelerated hypertension. I've already told you dyskidema is a feature of malignant bar accelerated hypertension. Malignant hypertension can be sudden, unilateral, bilateral loss of vision. Yes, it is a feature of malignant hypertension. Patient can have a unilateral or bilateral loss of vision. In malignant hypertension, without vision loss, BP should be brought down rapidly. So that's a very important clinical question. In malignant hypertension without vision loss, BP should be brought down slowly and judiciously. If you rapidly bring down the BP, the perfusion to the neurological tissues, including the optic nerve, gets compromised, and a patient may show sudden loss of vision, or patient may develop a stroke. So in malignant hypertension without vision loss, BP should be brought down slowly and judiciously. That is a clinical question there. So the first choice there, BP goes above 140 millimeters of diastolic, then dyskidema develops rapidly. It's a very, very important fact. When BP goes above 140 millimeters of mercury, diastolic BP, then dyskidema will develop in minutes. And another important point there is malignant hypertension, ROP should be brought down slowly and judiciously. Otherwise, the neurological tissues, including the optic nerve, goes for infarction. So the answer to this question is it should be brought down rapidly, D. So fundus, another very, very simple common question that is being asked is fundus diabetes. Fundus diabeticus is full-blown diabetic retinopathy, bilateral vitreous hemorrhage, mild and non-proliferative diabetic retinopathy, only venous dilatation. It is, you may be just carried away with the choice A, but it is not true. It is actually only venous dilatation seen in fundus. So it is fundus diabeticus is the venous dilatation seen in diabetic patients. It probably will be there in every vein in the body in diabetes, but it is visible in the retina in diabetes. So a patient with the diabetes may have a marginally dilated veins. So that is visible in the retina. So that finding is called fundus diabeticus. It has nothing to do with diabetic retinopathy. Okay. So fundus diabetes, another common question that is asked, is only venous dilatation seen in diabetic patients. So which is not true regarding diabetic retinopathy. Is the main risk factor for the duration of diabetes? Yes, the main risk factor for diabetic retinopathy is the duration of diabetes. Strict control of hyperglycemia delays the onset of diabetic retinopathy. Yes, that is again another fact. Strict control of hyperglycemia delays the onset of diabetic retinopathy. Diabetic retinopathy patients are likely to have nephropathy. Yes, the two organs that is involved in parallel are the eye and the kidney. You all know that. So all these choices are correct. Comorbidities like hypertension, dyslipidemia have no bearing on the onset of diabetic retinopathy. If somebody is having diabetes, if the patient is having hypertension, if the patient is anemia, patient is having dyslipidemia, they are likely to develop early onset of diabetic retinopathy. So the choice D is the answer, which is not true regarding diabetes. So another very common question that is asked from this is, which is the factor which is most often associated with diabetic retinopathy? The answer to this is the duration of diabetes, not the absolute value of diabetes. which is not true regarding diabetes. Decreased reading capacity, yes, probably the patient may have a decreased reading capacity because the patient may be having a macular edema due to diabetes, or the patient may be developing a cataract, so the patient may be having a reduced reading capacity. Patient may be seeing floaters, yes, patient may be developing diabetic retinopathy and then developing vitreous hemorrhage, patient may be seeing floaters. Patient may be developing sudden altitudinal field defects. Patient may be developing sudden altitudinal field defects. Yes, patients with diabetes can have a disease called anterior ischemic optic neuropathy, and patient may go into sudden altitudinal field defects. These patients may develop cortical cataract because because of the metabolic problem, the cortex gets opacified. So the patient develops a cortical cataract, and so that is the answer to this question. So this was an AIMS question which has been asked repeatedly in various entrance examinations across the country. So patient may develop decreased reading capacity because of macular edema, or maybe because of the cataract. Patient may see floaters because the patient must be developing a vitreous hemorrhage. Patient may be developing an anterior ischemic optic neuropathy. So the patient, a disease, anterior ischemic optic neuropathy is notorious to produce altitudinal field defects. Anterior ischemic optic neuropathy. Okay, the answer to this is D. Which is again true regarding diabetes. Posterior subcapsular cataract can develop. Yes, you know, the posterior, the diabetic cataract is a posterior subcapsular cataract. Diabetic cataract is also called snowflake cataract. Yes. Don't forget the sugar is just looking like snowflakes. So it is a snowflake cataract. Diabetic. So diabetic cataract is called snowflake cataract, and patients diabetic cataract develops at an earlier age. All these are true. Posterior subcapsular cataract can develop in these patients. Diabetic cataract is called snowflake cataract. Diabetic cataract develops at an earlier age. I have already told you in the previous MCQ that these patients develop something called cortical cataract. So these patients are likely to develop something called hypermetropia. So this also, again, in some textbooks, it's given as myopia develops in hyperglycemia, but that is not true. So these three things, patient develop diabetic cataract can develop as a posterior subcapsular cataract. Typically diabetic cataract is called a snowflake cataract, another very common entrance question. And diabetic cataract develops at an earlier age. And these patients develop hypermetropia because of this diabetic cataract. So the answer to this question is myopia develops during hyperglycemia. So exudative detachment. So this I have included all these retinal questions from the retina as the initial part of this question, because you know majority of the questions for all the premier, all the major entrance examination, majority of the questions comes from retinal diseases with which we are not much familiar. So I thought I will introduce these questions first, but they are a little tougher than the other questions. Exudative retinal detachment is produced by all except. So exudative retinal detachment is produced by, you should know the list of conditions where exudative retinal detachment is formed. Retinal detachment because of the collection of fluid behind the retina without a retinal break. That's called exudative retinal detachment. This may be because the fluid secreted by a tumor, for example, the retinoblastoma, malignant melanoma, or systemic conditions like anemia, pregnancy-induced hypertension, the preeclampsia, eclampsia, these conditions produces exudative retinal detachment. Uremia again produces retinal detachment. So these three conditions, along with tumors, produces exudative retinal detachment. So, but not leukemia. All are true about Coats disease. I think you probably may not be knowing anything about this disease. You can just learn all the facts about this disease from this MCQ. The first choice, the choice B is the most important feature of this condition. It is common in males and it is unilateral. Here, what happens is the patients with Coats disease have certain angiomas in the retina. What will happen is these angiomas will leak exudation subretinally. So what will happen? This exudates, that is the the plasma proteins and other things which are coming out of the vessel or the in the angiomas go subretinally. They get collected there. So what will happen? Retina get detached from choroid. So retina comes forward and comes and occupies behind the lens. You may see a white reflex behind the lens. So mind you, this is a condition where will you see the white reflex of the people. Another entrance question. Cause disease is a cause of the white reflex of the people. So you understood. Retina gets detached and comes forward and comes and occupies behind the lens because of the exudation from the angiomas in the retina. This is common in males and is unilateral. It's in only one eye. And the patient may present with white reflex of the pupil. So that is called the amerotic cat's eye reflex. So the patient may come with the white reflex of the eye, or this is again a very common question. White reflex of the eye is in Coats disease, and the patient may present with squint or a strabismus. This was one of the common questions that used to come for the AIMS entrance examinations. So Coats disease is common in males and is unilateral and is due to angiomas in the retina which will leak subretinally, causing retinal detachment. Retina comes anteriorly and comes occupy behind the lens, and so you will see a white reflex in the pupil. The patient may present with a strabismus, or patient may present with a white reflex of the pupil. Okay, when somebody takes a photograph of the child, you will see the retro illumination on people while the other people show a white reflex. So other conditions producing white reflex, you should be very familiar with the conditions which produces white reflex. One is retinoblastoma, second is Coats disease, third is the organized vitreous hemorrhage. But there is sometimes you will get a question with a choice of congenital cataract. Does it produce white reflex of the people? No. Many of our students have gone wrong by answering this question. Congenital cataract is not a cause of white reflex of the people. So to call white reflex, it should be behind the lens. The pathology should be behind the lens. Here it is in the lens. So congenital cataract is not a cause of white reflex of the people. This you should all know because they very commonly asked entrance question, and very commonly students will fail in this question. So congenital cataract is not a cause of white reflex of the people. The very common causes are the retinoblastoma, Coats disease, then you will have organized vitreous hemorrhage, so many other conditions. So now see the most appropriate method of follow-up of the other eye of a child who has an enucleated eye due to retinoblastoma. One eye of the child is enucleated due to retinoblastoma. What is the most appropriate method of follow-up of the other eye of a child? This is a question which again is asked for an AIMS. And this question is the sentence in Parson is you have to learn. Somebody has lost one eye due to retinoblastoma. He has to undergo fundus examination, indirect ophthalmoscopic examination yearly throughout lifetime. You understood? Because this patient can develop an adult retinoblastoma. So you should see whether the one eye is enucleated due to retinoblastoma, other eye should be examined throughout lifetime with indirect ophthalmoscopy. And that too, if you see the sentence of Parson, it is indirect ophthalmoscopy yearly throughout lifetime in a fully dilated people. People should be dilated and should be and patient should undergo a scleral indentation. Very important point. I don't know, somebody has asked this question, somebody else sees this question, you look into this chapter and may come up with another question by asking this. So the indirect ophthalmoscopy yearly throughout lifetime in a fully dilated people with pressing the sclera, so that you should visualize so that we can visualize the entire retina. That is the idea. So indirect ophthalmoscopy yearly throughout lifetime with scleral indentation, a fully dilated people. That is the most appropriate method of follow-up of other eye of a child who has already an enucleated eye. All are true regarding enucleation retinoblastoma except minimum manipulation. You know, this is a tumor which spreads by blood, so there should be minimum manipulation while you do surgery because the tumor cells may spread through blood. The longest possible optic nerve should be cut. This again is a repeat entrance question. Longest possible optic nerve should be cut because the tumor extends into the CNS along the optic nerve. So you don't know how far the tumor has spread. So you should cut the longest possible optic nerve when you nuclei in the eye for retinoblastoma. Bleeding may be a problem. Yes, bleeding is a problem in retinoblastoma surgery. And bleeding of optic foramen is seen. So bleeding of optic foramen is seen. So actually what happens, the tumor extends along the optic nerve. So what will happen? The optic nerve will go into irregular thickening. Some part of the optic nerve is thickened, some part of the optic nerve is not thickened. So that is how you know that tumor is extending along the optic nerve. What will happen? Because this irregular swelling of the optic nerve, this optic nerve will erode the optic foramen and the optic foramen will widen. So the point is, it is a bleeding of the optic nerve and the widening of the optic foramen. See how deep they have asked this question. So it's a bleeding of the optic nerve and the widening of the optic foramen. These are the findings of retinoblastoma. So they have just confused by adding these two words. It's a bleeding of the optic nerve. Bleeding of the optic nerve means an irregular thickening of the optic nerve, but and a widening of the optic foramen. These are the findings in retinoblastoma. So the answer to this is D. All are true associations. All are the associations. Retinitis pigmentosa, except. So this again is another common entrance question. Retinitis pigmentosa. Before going to these questions, I think we should look into we should remember the fundus drawing that all of us have drawn. That is retinitis pigmentosa. Retinitis pigmentosa is a condition where there is night vision problem, where the rods, the photoreceptor rods are damaged. The patients will have night vision or nyctalopia, night vision problem of the nyctalopia. And these patients have so many associated findings in the eye. The patient may some called the cornea of the patient. If you look at from the anterior to posterior of the eye, the patients may have a floppy iris, a floppy eyelid. That means the eyelid is stretchable. You can just pull down the eyelid and the eyelid will stretch like an elastic rubber band. Behind that, the cornea is more curved. That condition is called the keratoconus. Behind that, the intraocular pressure of the eye is raised. That is called primary open angle glaucoma. Behind that, the lens, you will see a posterior subcapsular cataract, a complicated cataract. Behind that, the vitreous is separated from the retina. That is called posterior vitreous detachment. Behind that, there is something called drusen of the optic nerve head. And looking at this, so the patient may have floppy eyelid, the patient may have a keratoconus, patient may have primary open angle glaucoma, patient may have cataract, patient may have posterior vitreous detachment, patient may have a drusen of the optic nerve, and the patient may have Coats-like telangiectasia of the retina. Patient may have something like Coats disease-like appearance of the fundus. So these are all associations of retinitis pigmentosa, and this has been asked in varying combinations in various entrance examinations. So I'll repeat, drusen of the associations are a floppy eyelid, keratoconus, primary open angle glaucoma, posterior subcapsular cataract, posterior vitreous detachment, drusen of the optic nerve, and the Coats-like telangiectasia of the retina. So by looking at this, keratoconus produces myopia. So the answer to this is hypermetropy. Oh, this again another common question: congenital hypertrophy of the retinal pigment epithelium. So this is the thing. When you look at a fundus, patient must have come for some other finding. Eye examiner, you happen to see these patients like this black scar there. This is called congenital hypertrophy of the retinal pigment epithelium. So this finding is actually suggests the patients may have a premalignant condition in the colon, and that is called familial adenomatosis coli. So these patients may probably require, many of these patients may require colectomy to prevent a colonic carcinoma in this patient. So the congenital hypertrophy, this question had been asked. Original question came like this: CHRP, congenital hypertrophy of the retinal pigment epithelium, is associated with the premalignant condition of the colon. So this is the congenital hypertrophy of the retinal pigment epithelium. These are multiple congenital hypertrophy of the retinal pigment epithelium seen in this patient. So these are multiple ones. So And we have seen so many findings in retinitis pigmentosa. One is called this bony spicule pigmentation that we see in the fundus, and this is the bony spicule pigmentation. You also see that the artery is attenuated. We cannot trace the artery, but we can see the vein here. So the most reliable sign, and you can see the pallor of the disc. So the most reliable sign in the in retinitis pigmentosa, again asked as an entrance question, most reliable sign is an arterial attenuation. Artery get attenuated, and the least reliable sign is the waxy pallor of the disc. So the most reliable sign in retinitis pigmentosa is the arterial attenuation, while the least reliable sign is the waxy pallor of the disc. There is nothing to do with the bony spicule pigmentation. Don't be carried away with the beautiful finding, like beautiful finding in the fundus, that is the bony spicule pigmentation. Nothing to do with the entrance examination. The most reliable sign in retinitis pigmentosa is arterial attenuation, while least reliable sign is the waxy pallor of the disc. Don't forget this. So Salmon patch hemorrhages. Salmon patch hemorrhages are hemorrhages seen in the fundus in patients with a disease called, you must all be familiar with this disease, sickle cell disease. So this is again a tricky question there in the entrance examination. If you have given a Salmon patch, Salmon patch means a patch seen is an interstitial keratitis seen in congenital syphilis in the cornea. So Salmon patch is a interstitial keratitis seen in the cornea in congenital syphilis, while Salmon patch hemorrhages are a feature of a disease called sickle cell retinopathy. Don't be, you really have to look into this question, what they have asked, whether it is Salmon patch or a Salmon patch hemorrhage. Hemorrhage means a retinopathy, so it is sickle cell retinopathy. So this is the Salmon patch hemorrhages that you see in patients with the sickle. This is a small bleed there, which they say is having the color of the fish called sickle cell, salmon. All are true regarding sickle cell disease. Again, very difficult question that came for the entrance examination. Coma-shaped conjunctival vessels. Yes, this is a feature of a disease called a sickle cell disease. These patients with sickle cell disease will have coma-shaped dilated conjunctival vessels. These patients will have hypochromic spots in the iris. You all know that in sickle cell, the RBC is having sickle shape, and so they don't flow in small vessels in the iris, and so that small areas of the iris dies off, and so that areas will become hypochromic. Similarly, same problem happens in the retina, so they will have hypochromic spots in the iris, you will have hypochromic spots in the retina. Clinically milder disease produces milder forms of retinopathy. No. Sickles, the SS disease, that is the most systemically active disease, does not produce much of the ophthalmic findings. SS disease, the homozygous condition, does not produce much of the ophthalmic findings. But clinically mild disease like SC disease produces the most severe form of retinopathy. Again, another common entrance question. This question had been repeated by AIMS previously. So clinically mild disease like SC disease produces most severe forms of retinopathy. Okay. Another very common question that have been asked is you see a neovascularization of the fundus, which is having the shape of a fan-like appearance. So this appearance is called the C-fan neovascularization. C-fan neovascularization. Again, the condition is sickle cell retinopathy. Okay, Salmon patch hemorrhages, clinically mild diseases produces most severe forms of the retinopathy, and C-fan neovascularization. Again, sickle cell disease. So again, all are for fundus features of leukemia. So venous dilatation, yes. Soft exudates, no. Hard exudate, yes. Hemorrhages. But this is an ambiguous question which has been asked many times in the entrance examination. And hard exudate is not a feature of leukemia. You have to remember like that. Hard exudates are not a feature of leukemia. And in the fundus, you see the malignant cells coming and occupying in the fundus, clumped together like a leopard, like the spots in a leopard. So that's called leopard spot. So hard exudate is not a feature of leukemia, and leopard spots are a feature of leukemia. So, which is not true regarding central retinal artery occlusion. It's an ophthalmic emergency. Yes. Cardiac disorder is the commonest cause in elderly. Yes. Yes or no? Hollenhorst plaques usually do not produce central retinal artery occlusion. Yes, Hollenhorst plaques are fibrinoplatelet emboli. They are so small to produce any vessel occlusion. Polyarteritis nodosa can cause central retinal artery occlusion. Yes. Cardiac disorder is the commonest cause of central retinal artery occlusion in children, while In adult, it is the carotid atheromatous plaque is the commonest cause of central retinal artery occlusion. So again, another common entrance question. So remember, carotid atheromatous plaque is the commonest cause of central retinal artery occlusion in an elderly, while in a child, it is the cardiac disorder is the most common cause. So you see this picture, you can get even a picture like this for your entrance examination, and you will see the retina is pale, surrounding retina is pale with a center red spot. This is called a cherry red spot. Here you can see that again another entrance question that had been asked for AIIMS. This is the white area in the fundus, and you will see from the area from the disc to the macula is again red. We are expecting it to be white like this, and this is called the central artery occlusion with persistent cilioretinal artery. So there was an entrance question. A patient with central artery occlusion usually does not have vision. But if the patient is having vision, that means the patient is having something called persistent cilioretinal artery. So cilioretinal artery is another artery which is supplying the macula. Generally, it is supplied by central retinal artery, but there is another artery which is not from the retinal circulation, but comes from the choroidal circulation and supplies the macula. So that is why this area is red. This is called cilioretinal artery, which is present in a very less percentage of people. So somebody who is very lucky is having cilioretinal artery, develops central retinal artery occlusion, he will still maintain vision. So the entrance question was a patient who had undergone central retinal artery occlusion but is having very good vision. That means the patient is having a persistent cilioretinal artery. Okay. Which is true regarding central retinal artery occlusion. Chance of neovascular glaucoma is more than that of CRVO. The treatment of choice IV heparin. The 5-year mortality of central artery occlusion is 20%. Central artery occlusion cannot occur in young people. That is for you. The choice D. You are sure that central artery occlusion occurs in young people and where cardiac disorder is the commonest cause. Mind you, somebody who has developed central artery occlusion in the past, 20% of these patients are likely to die in the next 5 years. So 5-year mortality is 20%. And the chance of neovascular glaucoma is more than that of CRVO. You know, central retinal vein occlusion is notorious to produce neovascular glaucoma. So you should be during your MBBS classes, you must have heard neovascular glaucoma is produced by central retinal vein occlusion. So the chance of neovascular glaucoma is more with central retinal vein occlusion, and is less with the central retinal artery occlusion. And so that choice is wrong. Treatment of choice is IV heparin. No, the treatment of choice is to reduce the intraocular pressure. So you know there is a pressure which is acting on the vessels in the eye. That is intraocular pressure. If you reduce the intraocular pressure by some means, by giving IV acetazolamide, or you can also do an opening into the eye, that's called paracentesis. You let out some little bit of aqueous humor from the eye so that the intraocular pressure reduces, so that the partially blocked vessel now start flowing. So the treatment of choice is to reduce the intraocular pressure. It's not IV heparin. The 5-year mortality is 20%. CRA cannot occur in young people. So the answer to this question is C. So you have to remember that 20% of all patients who have developed CRVO will die in the next 5 years. Another very difficult question came for entrance examination, AIIMS. All are true regarding CRVO except central retinal vein occlusion. Listen to me now. Central retinal vein occlusion is of 2 types. One is called an ischemic central retinal vein occlusion, and another is called a non-ischemic central retinal vein occlusion. In ischemic central retinal vein occlusion, as the word sounds, it must be more severe, where the patient's vision will be very less than 6/60. Patient may have a relative afferent pupillary defect, so vision is less. Patient may have a relative afferent pupillary defect, and the fundus is covered with hemorrhages, and this appearance of the fundus is called the tomato ketchup appearance or a thunderstorm appearance. So either of this. So this is a more severe form. Ischemic CRVO is called the ischemic CRVO is the most severe form of the of CRVO, where the patient vision is very less. Patient may have a relative afferent pupillary defect, and the patient's fundus is covered with hemorrhages, which is called a tomato ketchup or a thunderstorm appearance. So that naturally means the non-ischemic CRO of the vision is good. There is no relative afferent pupillary defect. Fundus is not having full of hemorrhages. But both these type of CROs will reduce vision by producing macular edema, because the drainage of the blood from inside the eye to out is impeded. So that will the macula get edematous. So whether it is non-ischemic CRO or ischemic CRO, vision drops by a macular edema. So now you read. Rapid relative afferent pupillary defect, markedly decreased vision are the features of ischemic CRO. Yes, that's right. Posterior pole of the fundus will be covered with hemorrhages in ischemic CRO. Yes. Non-ischemic CRO may get converted into another important feature. The patient may have a non-ischemic CRO to start with, which will later get converted into an ischemic CRO. Non-ischemic CRO cannot produce macular edema. I have told you, whether it is non-ischemic, whether it is ischemic, patient vision drops because of macular edema produced by either of these types. So this is a non-ischemic CRO, but this is an ischemic CRO. I told you the fundus is covered with hemorrhages. It's called a thunderstorm or chromatopathic appearance. Now, the indication for laser photocoagulation CRO, another common question that came frames. Indication for laser photocoagulation central retinal vein occlusion, neovascularization of the ankle or the iris. You know, neovascular glaucoma. You know, in central retinal vein occlusion, the venous drainage from inside the eye is impeded. That means there is stasis in the veins, there is stasis in the venules, so there is stasis in the capillaries. That means less blood is reaching the eye. So the patient is developing ischemia to the retina. So what will happen? Now the retina will now elaborate vascular endothelial growth factor. This vascular endothelial growth factor will migrate along the vitreous, come anteriorly, producing new vessels in the ankle and the iris. At the same time, it also produces neovascular, the VEGF will produce new vessels in the retina. So it produces new vessels in the retina, it produces new vessels in the iris and the angle. So the patient will go for neovascular glaucoma because aqueous humor cannot drain through the trabecular aperture where it is covered with blood vessels. So the patient will develop neovascular glaucoma. So what is the treatment? You ablate the source of source of VEGF. The source of VEGF is the retina. So you ablate the retina with laser, so that the source of VEGF is reduced, so that the VEGF upregulation is reduced, so that new vessels regresses. So the indication for laser photocoagulation CRO is neovascularization of the ankle and the iris and neovascular glaucoma. If the patient is already neovascular, still we have to ablate the retina. So A and B are correct. So this is a patient with the neovascular glaucoma. You can see the new vessels in the iris is bleeding and producing blood in the anterior chamber. Blood in the anterior chamber is called hyphema. So which is not true about radiation retinopathy. Another common question, radiation retinopathy. Radiation retinopathy is exactly mimics the diabetic retinopathy. It is asymptomatic, just like diabetes retinopathy as the early on. The fundus is just like diabetic retinopathy, and the treatment is pan-retinal photocoagulation, just like diabetic. So the treatment of diabetic retinopathy is pan-retinal photocoagulation. The treatment of radiation retinopathy is again pan-retinal photocoagulation. It is just like diabetic retinopathy, but it is dose dependent. Somebody has developed more radiation, he is likely to develop radiation retinopathy early on. So it is dose dependent. So answer to this question is A. So which is not a physiological feature or physiological effect of pregnancy. Lid telangiectasia, you know, pregnancy is a condition where fluid retains inside in the body. So what will happen now? Fluid is retained in the eyelid, so the eyelid gets swollen, the vessels stand out. So there is lid telangiectasia. The fluid retained in the body, it's also retained in the cornea. So the cornea develops edema. So the fluid is retained in the body, so fluid is retained under the retina. The patient develops something called central serous retinopathy. The patients may have slightly raised intraocular pressure. The fluid retained inside the eye, so the patient may have slightly raised intraocular pressure. Not always. That is the clue in this question. You see, patients with patients in pregnancy generally have a raised intraocular pressure, but the patients can have also a low intraocular pressure because of the sympathetic activity is less in these patients in pregnancy. So what will happen? This question, lid telangiectasia, yes, the eyelid is swollen, vessels can stand out. It is physiological. Cornea, fluid is retained in the cornea. Cornea get edematous. Generally, the intraocular pressure is high, but a patient can also have a low intraocular pressure. You know, central serous retinopathy is not a physiological state. It's a pathological condition. It is where a vessel in the choroid or somewhere in the retina leaks. So the pathology has developed there, and that is causing the accumulation of fluid under the retina, central serous retinopathy. The question looks very innocuous, but the clue is that CSR is not a physiological condition. It is a pathological state. Okay. Which is not true about, again, pregnancy. Diabetic retinopathy worsens, thyroid ophthalmopathy worsens, pituitary adenoma may first present with field defects, uveal melanoma may decrease in size. So, you know, pregnancy is a condition where all the endocrinological diseases worsen. So, diabetic retinopathy worsens, yes. Thyroid ophthalmopathy worsens, yes. Pituitary adenoma may first present, a microadenoma first present with field defects or endocrine defects in these patients. You know, uveal melanoma, these melanomas are a situation where all the pigmented lesions of the body will increase in size in pregnancy. All the pigmented, because of the increased secretion of the MSH. So a uveal melanoma, that means a melanoma of the choroid or the iris, which is also increased by the secretion of MSH. So all these melanomas, all the pigmented lesions in the body will increase in pregnancy. So a uveal melanoma will also increase in size. So the answer to this is D. It doesn't decrease, but it's increased in size. A diabetic retinopathy worsens, thyroid ophthalmopathy worsens, all the endocrinologic disorders worsens, and all the pigmented lesions in the body increase in size. And so the uveal melanoma may increase in size. So that is the answer to this question. So another very, very common entrance question is on retinopathy of prematurity. So I'm almost sure that you are likely to develop, you are likely to get questions on retinopathy of prematurity. Before discussing this question, you better listen to me and understand these facts, so that it's very easy to answer these questions. So retinopathy of prematurity is a disease where you know that when everybody is born, the retinal vessels are reaching up to the nasal retinal periphery, and the retinal vessels are not reaching up to the temporal retinal periphery. That means some part of the temporal retina is avascular. But this temporal retina, avascular retina, will get vascularized in few weeks' time. Imagine a premature baby is born. The nasal vessels may not reach the retinal periphery. Temporal vessels will not reach the temporal retinal periphery. That means a large part of the temporal retina is avascular. Avascular means ischemia. So what will happen? The VEGF upregulations from there. VEGF will be released, which will produce new blood vessels, which will bleed into the vitreous. With blood get organized, and blood will become fibrous tissue-like. So it pull out the retina. So retina may come out, and retina may come occupy behind the lens. So again, white reflex of the pupil in retinopathy of prematurity. So this is a situation. So this can be worsened by. So retinopathy of prematurity is because the child is born with prematurity, so that retinal vessels are not reaching up to the retinal periphery. Large area of the retina is avascular. VEGF upregulation. VEGF will produce new blood vessels in the retina. It will bleed into the vitreous. That get organized. Vitreous get organized. It pull out the retina. That's called tractional retinal detachment. And retina now comes occupied behind the lens. So this is called retrolendal fibroplasia. Retinopathy of prematurity, sometimes called retrolendal fibroplasia. That means retina comes and occupies behind the lens. So this is again another cause of white reflex in the people. So take down these. Retinopathy of prematurity occurs when the birth weight is less than 1.5 kg, when there is prematurity, when there is supplemental oxygen. Okay. So prematurity, low birth weight, supplemental oxygen. Because of our excellent neonatal care now, babies 600 grams, 700 grams children are surviving. They are being given oxygen. So what will happen? The baby may be likely to go into retinopathy of prematurity. So all these factors, prematurity, low birth weight, supplemental oxygen, all these are the features of retinopathy of prematurity. So retinopathy of prematurity may be aggravated by neonatal hyperglycemia, neonatal hypoglycemia, neonatal septicemia, abruptio placenta, respiratory distress syndrome, and hyaline membrane disease. All these will increase the risk of retinopathy of prematurity. So neonatal hypoglycemia, hyperglycemia, neonatal sepsis, abruptio placenta, hyaline membrane disease, respiratory distress syndrome, all these will increase the risk of retinopathy of prematurity. So now, but it should not develop now, because baby should survive. At the same time, the baby should not develop retinopathy of prematurity, so that every neonate should undergo a screening to look for retinopathy of prematurity. Every premature baby that is born should undergo a screening for retinopathy of prematurity by the first month, by the 30th day after birth. By the 30th day of birth, every baby who is premature should undergo an examination for retinopathy of prematurity. If there is a retinopathy of prematurity, you have to just ablate the peripheral retina with laser or cryo, which is a source of VEGF. So you are just damaging the peripheral retina, which is a source of VEGF. And so that peripheral retina is not very important for the vision, but you just ablate the retina so that VEGF is not produced, so that no new blood vessels are produced, so no vitreous hemorrhage, no traction retina. That is the idea. This is generally done in the ICU, neonatal ICU. So that is a treatment. Treatment is laser or cryotherapy of the peripheral retina. So another entrance question is plus disease. Plus disease in ROP means markedly dilated and tortuous veins. You cannot dilate the vessels have come not only into the retina, now the vessels have come into the iris. So you should not be able to dilate the fundus, dilate the pupil to visualize the fundus. The vessels will be markedly dilated. You cannot see very clearly into the retina. So that is plus disease. That means ROP plus. Plus means something severe. So severe means you are not even able to dilate the fundus and visualize the pupil, because the vessels may not only appear in the retina, may come into the iris, and you will not be able to dilate and visualize the fundus. So plus disease in ROP means dilatation, tortuosity of the veins. Vitreous is engorged iris vessels, and widely you will not be able to dilate very, very difficult to dilate the people in these plus disease patients. So these are you can see fundus of these patients, where you see the red area and you see a black bluish area which is avascular in the periphery, and you will see a demarcation area which separates the red and the blue area. So this is called the demarcation line. You may probably, somebody will ask you an entrance question, where is demarcation line seen? Demarcation line is a feature of retinopathy of prematurity. Sometimes this demarcation line may have blood vessels growing, and so this is called the ridge. So somebody may ask you a question, demarcation and line or ridge is a feature of what disease? It's a feature of disease called the retinopathy of premature, demarcation line and ridge. So another common entrance question is ocular ischemic syndrome. This is a condition where the carotid arteries goes for more than 75% occlusion. So when the carotid artery goes more than 75 occlusion, the circulation to the eye get affected, and what will happen again? All these problems of ischemia that I told you, that is VEGF upregulation, new blood vessel formation, everything will develop. So these patients have venous dilatation. So every retinal disease have vein is dilated. See, whether it is in central retinal artery occlusion or any other disease, when the vein is dilated, it is also tortuous. So this is the only clinical condition where venous dilatation without tortuosity. That is why these entrance questions keep on coming. The most specific finding of ocular ischemic syndrome is venous dilatation without tortuosity. Because the carotid artery is occluded for more than 75%, ischemia to the eye, patient may have pain. Patient will have severe pain. And the patient will have corneal edema. Patient will have anterior chamber cells and flare as in uveitis, and the patients may have cataract, patient may have engorged iris vessel. Mind you, remember, this is not a common disease that you have learned. This is because more than 75% occlusion of the carotid artery, the circulation to the eye is affected. Patient may present with ischemia to the eye and ischemic pain, just like the cardiac pain. The patient has severe pain in the eye, and the patient may have on examination corneal edema, anterior chamber cells and flare, cataract, and engorged iris vessels. These features have been asked as entrance question. So corneal edema, anterior chamber cells and flare, engorged iris vessels, cataract, and when you see the fundus, venous dilatation without tortuosity. There may be hemorrhage, exudates, everything. All these will be there, but very important feature is venous dilatation without tortuosity. That's a more specific sign of ocular ischemic syndrome. So another question from ocular ischemic syndrome, which is not true regarding ocular ischemic syndrome. Carotid atherosclerosis is the most common cause. Yes, that is the most common cause. 50% of the patients with ocular ischemic syndrome are likely to develop ISD, ischemic heart disease, in the next 5 years. 25% of these patients are likely to develop stroke, and the 5-year mortality is 50%. What is the 5-year mortality of central retinal artery? We have just learned that is 20%. But a 5-year mortality of ocular ischemic syndrome is 50%. So mind you, 50% of these patients are likely to develop ischemic heart disease, 25% of them will likely to develop stroke, and 50% of all these patients who have ocular ischemic syndrome are likely to die in the next 50 years. So the 5-year mortality of this condition is more than that of CRA, which is only 20%. So these questions on and retinal vein occlusion, ocular ischemic syndrome are one of the most difficult questions ever had come for AIIMS entrance examinations previously. So now we will go into some of the simpler, probably simpler questions. Which among the following is an acquired cause of cherry red spot in the macula? Mind you, one of the most common causes questions that have been asked is, which is the commonest cause of cherry red spot in the macula? The answer to this question is trauma. Okay. The most common cause is trauma. So what is the answer to this question? So it is commercial retina or the Berlin's edema that occurs because of trauma. So many of our students have gone wrong by answering it as many other the answers. They can all produce this, but the problem is they are congenital causes. The most common cause or the most common acquired cause. If you take all diseases which is common, trauma is common. So the most common cause is commercial retina or the Berlin's edema, which is the most common cause of blunt injury to the eye. That is the commonest cause of cherry red spot of the macula. So again, another one of the difficult questions that had come for the AIIMS entrance examination: high-risk characteristics in PDR, proliferative diabetic retinopathy. What are the high-risk problems? So high-risk problems are, high-risk means high-risk characteristics that is necessitating laser photocoagulation in the retina. So high-risk characteristics in proliferative diabetic retinopathy are neovascularization of the disc. If majority of the disc is having new blood vessel, that means the patient has to undergo panretinal photocoagulation. Another important high-risk characteristic is neovascularization. It may not be the majority of the disc is not involved, but it is associated with the vitreous hemorrhage or neovascularization elsewhere. To simply remember, it is the disc neovascularization with or without hemorrhages, without vitreous hemorrhage, or neovascular elsewhere. That means neovascularization in the retina, which should be slightly larger with vitreous hemorrhage. So neovascularization disc or the neovascularization of the retina, that is called NVE. The original question came with this abbreviation, so we should be knowing these abbreviations. Neovascularization of the disc or the neovascularization of the retina, they are high-risk characteristics. But neovascularization, iris, NVI, I told you high-risk characteristic is characteristic necessitating laser photocoagulation. I told you previously in one of the MCQs, in central retinal vein occlusion, neovascularization of the iris, when you see neovascularization of the iris, you ablate the retina with laser. But in diabetic retinopathy, it is neovascularization of the retina or the disc that will tell you should ablate the retina so that the VEGF production is reduced. So both are different. So in PDR, proliferative diabetic, the high-risk characteristic NVD, neovascular disc or neovascularization retina, while neovascularization of the iris is the high-risk characteristic in necessitating laser photocoagulation in central retinal vein occlusion. Both are different. So I cannot explain more because of the lack of time. Which is not true regarding diabetic retinopathy with vitreous hemorrhage. Somebody has come with you with a very, very common question. See, it has been asked for the entrance examination. It has been asked for the PGA previously. Now for the NEET entrance examination, this question came. Same question came, which is not true regarding diabetic retinopathy with vitreous hemorrhage. Somebody is having diabetic retinopathy with vitreous hemorrhage. This is PDR. This is proliferative diabetic retinopathy. This requires photocoagulation. Yes, I just told that somebody with neovascularization and vitreous hemorrhage requires photocoagulation. The risk for neovascular glaucoma is high. Yes, I told you the central retinal vein occlusion is commonly associated with neovascular glaucoma, but diabetic retinopathy is a more commoner disease than central retinal vein occlusion. So the most common cause producing neovascular glaucoma is diabetic retinopathy, but not central retinal vein occlusion. Many times this question come, people will go wrong. So the commonest cause of neovascular glaucoma is proliferative diabetic retinopathy, but central retinal vein occlusion is more commonly associated with neovascular glaucoma. But the most, mind you, this question should be very clear. The most common cause of neovascular glaucoma is diabetic retinopathy. If on aspirin, it has to be stopped. Here is the situation: somebody is having bleeding in the vitreous hemorrhage, VDS into the vitreous hemorrhage. If on aspirin, it has to be stopped. This is the very important fact. Aspirin will worsen hemorrhages in every other part of the body except in the vitreous. So if somebody is on aspirin for any other reason, patient is having vitreous hemorrhage, he need not stop aspirin. He is taking aspirin for cardiac problems or the stroke. He can very well continue aspirin even if the patient is having vitreous hemorrhage, because aspirin cannot worsen vitreous hemorrhage. So if you are on aspirin, it has to be stopped. That is a wrong answer. Okay. So which is not true regarding diabetic retinopathy with vitreous hemorrhage. This is PDR. Yes, PDR requires photocoagulation. Yes. The risk of neovascular glaucoma is, yes, it is high. If on aspirin, it has to be stopped. No, the patient can very well continue aspirin. Patient can very well continue aspirin even if there is a vitreous hemorrhage. So which is the laser most commonly used for retinal photocoagulation? So it is the frequency double Nd:YAG laser. So you must have heard when somebody talks about laser, the immediate thing that comes into our mind is Nd:YAG laser, because that is the only thing that you have heard coming into the medical school about laser. But you know, Nd:YAG laser is the laser used to do iridotomy or capsulotomy. Very clearly, you should understand, Nd:YAG laser is the laser that is used to produce iridotomy or capsulotomy. Its wavelength is 1064 nanometers. And its property is photo disruption. So Nd:YAG laser, which is having a wavelength of 1064 nanometers, having a property of photo disruption. So it just disrupts the iris to make an aorta in the iris, that is called iridotomy. It just disrupts the lens posterior capsule, producing an aorta in the posterior capsule, that is called capsulotomy. So Nd:YAG laser, wavelength 1064 nanometers with a physical property of photo disruption, and it is used to do capsulotomy or iridotomy. Well, frequency double YAG laser. So the frequency of this Nd:YAG laser is increased. So what is the frequency of this laser? 1064 will become half, that is 532 nanometers. So the frequency is increased. So what will happen when the frequency increases? Energy increases. So from disruption, the property now will become coagulation. So frequency double YAG laser. DF-YAG means frequency double Nd:YAG laser. So DF-YAG laser or the frequency double Nd:YAG laser with a physical property of photocoagulation is used to do retinal photocoagulation. You have now understood laser with a wavelength of 1064 nanometers, that is Nd:YAG laser, has got a property of photo disruption, and so it is used to do iridotomy or capsulotomy, while the frequency double YAG laser, which has a property of photocoagulation, because its frequency have decreased, so its wavelength has decreased, its frequency of its energy has increased. So now this laser is used for making photocoagulate the retina, and so that property of the frequency double YAG laser is photocoagulation, and that is the most common laser used to do the photocoagulation. And now when the frequency is further reduced, you may get other lasers called excimer laser. Excimer laser is having a property of photoablation. The name signifies excimer. So it's used to excise the cornea to correct refractive errors. So excimer laser, which has got a property of photoablation, is used to do LASIK, another entrance question. So as the wavelength decreases, the energy increases, the laser can be just used to cut the cornea. It can be just used as a blade that is used to cut the cornea. So it's called excimer laser. Excimer laser with the property of photoablation is used to do LASIK. So the most common laser used for retinal photocoagulation is frequency double YAG laser. So what will happen? Again, another entrance question of problems of photocoagulation. So you are just hitting the macula and you are just damaging the retina by photocoagulation. You will keep only the retina that is necessary for vision, that is the macula, the area between the disc and the macula. The peripheral retina is damaged or burnt with this laser. So the patient does not develop, the source of VEGF upregulation is decreased. So no new vessels are produced. So that is how you treat panretinal photocoagulation. That is how you treat the proliferative retinopathy. So when you are burning the peripheral retina, the patient's peripheral retina is lost. So the patient's field is lost. Patient field is reduced. That is the first problem of panretinal photocoagulation. Field is reduced. You know, so when the macula is damaged, when the optic nerve is damaged, you will see you will have a color vision problem of red-green deficiency. Red-green color vision deficiency because the optic nerve is damaged. You know, the optic nerve they are actually the axons of the neurons in the macula. So when the macular diseases or the optic nerve diseases, you will see the damage of the optic nerve and the color vision deficits, red-green color vision deficiency. That is why you see in optic neuritis, you will have red-green color deficiency. But if the peripheral retina is damaged, the cones from that area is actually producing, if the peripheral retina is damaged, the color vision produced is blue-yellow defects. Very important in this question. When the peripheral retina is damaged, the patient will have blue-yellow color vision deficits. So the peripheral retina is damaged by photocoagulation, so the patient will have blue-yellow color vision defects. So field is reduced, blue-yellow color vision defects. Now, along with this laser, you are hitting at one of the vessels. So the vessel will open up now, produce vitreous hemorrhage. So patient can develop vitreous hemorrhage, and patient, because the blood gets organized there, the patient may develop, tractional retinal detachment. You may even go, instead of hitting at a peripheral retina, you may go directly hit the macula of the patient, and the patient may develop whatever vision he is having, that is also lost. So patient can develop macular burns. You are leaving a lot of burning the retina. So you are leaving a lot of heat energy into the retina. So what will happen? Suppose the hot water falls into your hands, what will happen? You will develop scars, the fluid will accumulate behind the skin. Similarly, fluid will accumulate behind the retina. The retina now comes forward because the accumulation of fluid behind the retina. So that is called exudative retinal detachment. Now the retina comes forward and comes occupied behind the lens. And the iris, lens, everything now comes forward, producing angle closure glaucoma. So panretinal photocoagulation can produce ankle closure glaucoma, but not open angle glaucoma. So the answer to this question is open angle glaucoma. So another common condition, which is entrance question from retinal diseases, is central serous retinopathy. You know, central serous retinopathy is because of the accumulation of fluid only behind the macula, not into the periphery like retinal detachment, only behind the retina. This is seen in very young males, very anxious personalities. So what will happen is one of the vessels under the retina gets leaked, because this permeability of the vessel increases because of the endogenous level of steroids increases. So CSR can be common in situations where endogenous level of steroid is very high. So one of that is pregnancy. Another is that patients with type A personality. Third is males, young males. So what will happen is only the macula comes forward. The retina in the region of the macula comes forward. So the ray of light which was initially falling on the macula is now falling behind the retina, correct? Because the retina has come forward. So the patient is developing a refractive error called hypermetropia. Okay? 80% of these patients spontaneously resolve by 4 months' time. But if the patient does not resolve in 4 months' time, then the patient's leak has to be closed with lasers. So all these facts are entrance questions. 80% of the CSR spontaneously regresses by 4 months' time. If it doesn't regress by 4 months' time, you have to seal the leak of the vessel with lasers. Another situation where you have to seal with the lasers is bilateral central serous retinopathies. Or the patient cannot wait for 1 month. A pilot, he had to go for work very early. So professional needs, you can do early lasers. Otherwise, you have to wait for 4 months for spontaneous resolution of the laser, of the CSR. Again, another important entrance question, you will locate this site of leak using an angiogram, fluorescein angiogram. You will identify this site of leak, and the leak has got a pattern called the smokestack pattern or an ink blot pattern, which are the angiographic findings in CSR. So ink blot or smokestack, again asked as entrance questions. So this answer to this question is spontaneous resolution is rare. It is common. Spontaneous resolution is common. So this fact, 80% spontaneous resolved by 4 months' time has been repeated entrance questions previously for PGA exams. So indication for laser for the recurrent attacks, first attack not resolving 4 months, professionals, elderly. It's a disease of the young male, so it doesn't come in elder. So the answer to this is elder. Most common FFA finding in CSR is, this is one of the simpler questions where many of our students are gone. This is the ink blot pattern of smokestack, or this is the ink blot, and this is the smokestack appearance. In this patient, is got a smokestack here, an ink blot here. And this is a very beautiful dynamic appearance. You will see the smokestack will come and spreads like a mushroom. The very dynamic angiographic findings. Very beautiful findings. You know, beautiful things in life are deceptive. Ink blot is again a very rarely seen. Smokestack is a very rarely seen angiographic finding, seen in only 7 to 8% of the patient. This percentage was on asked as an entrance question. Smokestack is an angiographic finding in what percentage of CSR patients? Many of our students wrote 80%. It is not true. It's seen only in around 8%. Ink blot is seen in 80% of the patients with the CSR. So the most common FFA finding is ink blot. So this question was previously asked as an image question. This is the question was, what is this investigation? You all now know that this is an OCT finding, where you see this retinal pigment epithelium. This is the retina, and the retina is separated from the retinal pigment, the antimacula. And so this is a CSR. They did not ask for the diagnosis. They just asked, what is this image? This image of the OCT macula. So again, another retinal disease, which I think we will have only time to discuss retinal diseases. All are features of the Sickler syndrome, except. So this Sickler syndrome is again a very common question area for question setters. Sickler syndrome, you know, is an autosomal dominant condition where the patients has got all the diseases that you know is there in his eyes. Patient has a cataract, Patient have subluxation of the lens, that is called ectopia lentis. Patient have what other disease, cataract, then glaucoma, that is there. What other disease, for the patient, for a patient, ophthalmic patient, it is retinal detachment, that is also there. Patients may have lattice degeneration. Yes, it is lattice degeneration. Usually lattice is concentric to the ora serrata, but here it is vertical lattice. So the patient have all diseases that in the eye is there in the patient, in his eye. But when the patient has so many diseases, actually, normally when almost all retinal diseases, when patient multiple eye diseases, vitreous will be very opaque. Here, even though he has got cataract, he has got retinal diseases, he has all sort of diseases. Usually, when there are multiple problems in the eye, the vitreous will be opaque. But here is a condition for the multiple problems in the eye, but the patients will have optically clear vitreous. It's an autosomal dominant disease characterized by cataract, glaucoma, retinal degeneration, retinal detachment, and the vitreous is optically clear. They may have associated findings like telecanthus, that means his eyes are separated at a distance. Flattened nasal bridge, maxillary hyperplasia. He has got microphthalmia, he has a microstomia and micronappia. So the patient may have telecanthus, flattened nasal bridge, maxillary hyperplasia, microstomia, micronappia. Okay, all these facial features. With these patients may have myopia. So these varying combinations of this disease has been asked as entrance question: autosomal dominant disease, Stickler syndrome, characterized by these findings. So the answer to this is, even though the patient has multiple problems, his vitreous is very clear. So this almost completes the common questions from the retinal diseases. Common areas, I'm not telling common questions. Had I had, see this 35 odd or 30, nearly 40 questions which I have discussed, actually in the original classes, this will project to around 10 questions from each. That means around 400 questions of retinal diseases will be covered looking around these questions. I used to discuss 400 MCQs from the retinal diseases based on these questions. Mind you, these 400 questions had been facts about these 400 questions had appeared as entrance questions in various entrance examinations. And if you can study like that, I can assure you, you will be able to answer almost all questions from any entrance examination. And this that we have successively shown in our previous classes. Ophthalmology being a limited subject, we can really conquer the subject. But the problem is, the questions that we see in entrance examination of ophthalmology are not the usual theory questions that we study. It's all clinical questions, slightly advanced questions. But we were able to answer, we were able to correctly predict 80% of any entrance examination questions from ophthalmology in the last 10 years, which I used to take class. But because the lack of time, I'm sorry that we cannot go into the 400 odd questions, which was projected from these 40 questions, nearly 40 questions that we have discussed. Anyway, but we have not going to do anything. We have to just do whatever possible this time. So another, we are entering into another set of, I have already, I have just discussed you on lasers, their wavelengths, there are a lot of subjects, a lot of questions from that area, which I'm sorry that we were not able to discuss. Now we were discussing into another area which are unfamiliar to you, that is the strabismus. So why these entrance examination set-in questions are fitting on areas like retinal diseases and strabismus? Because these are the areas where the student is not much familiar. That is why they look into these questions. So these are the areas where we should thoroughly see. So you must have heard botulinum toxin. Okay. Botulinum toxin. So this is a magic drug actually. All are true except This is a drug which probably make our stars. Many of our stars are coming in the advertisement of many of our products. They are the 70s, 80s and all, with wrinkle-free face and wrinkle-free neck. The magic drug is botulinum toxin. This is the biggest weapon in the hands of so-called beauty therapists. Okay, so botulinum toxin, all are true except used for chemodenervation. Injection is to the paralyzed muscle, blocks acetylcholine release. Used when surgery is contraindicated. So this is used in ophthalmology. For example, somebody has developed a lateral rectus palsy. Imagine he has developed a lateral rectus palsy. He cannot look into the right side, left side, into the lateral side of each eye. Suppose he has right lateral rectus palsy, he cannot look into the right side. And he cannot walk because he see every image double. Okay. So you can bring in the eye because the lateral rectus is paralyzed, because the unopposed action of medial rectus, eye is moving towards the nose. That means the patient is developing a convergent squint. How can we move the eye centrally so that his double vision decreases? You paralyze the active muscle here. What is active muscle? Muscle is medial rectus. So where will you inject? You will inject into the very, very active opposite muscle. So that medial rectus. So injection is always to the very active muscle which is opposing the paralyzed muscle. That is the answer. Another entrance question that is asked for botulinum toxin is botulinum toxin acts by mechanism of action, acts by inhibiting acetylcholine release. It acts by inhibiting acetylcholine release. That is another common entrance question asked from this. So these patients, definite treatment is not injection into the medial rectus, but definite treatment is surgery. Till then, till the patient reaches surgery, you can inject in the medial rectus and makes the patient symptom-free, otherwise he'll see double vision. So, or when surgery is contraindicated because of some other reasons, you can just keep on injecting botulinum toxin. So it's a chemodenervation. I told you many of our stars use this to make our skin and wrinkle-free. So each injection costs probably around 2,500 rupees. However, varying, this is the cheapest rate, but you cannot, many of us stars can afford it. We cannot take the duration of action of this injection is only nearly 2 months. So we cannot keep on injecting every 2 months. It's very costly affair for us, but maybe for stars, this is affordable. So the entrance examination question in which we are interested is botulinum toxin acts by inhibiting acetylcholine release, and this injection is always to the opposite muscle of the paralyzed muscle. The muscle which is acting opposite to the paralyzed muscle. Our aim is to paralyze a muscle. So that is it. Botulinum toxin. Lost muscle in skin surgery, another common entrance question that had come. Many times this is asked. Lost muscle in skin surgery. Imagine somebody had come to you with for a surgery. She has got a convergent squint. So convergent squint is because of the active medial rectus which is contracting. Medial rectus is the strongest extraocular muscle. So you want to weaken the medial rectus by cutting out the medial rectus and moving it insertion little backwards in the glove. So this procedure of weakening the medial rectus is called recession, R-E-C-E-S-S-I-O-N. So in convergent skin, you may have to weaken the medial rectus. So to weaken the medial rectus, you may cut out the medial rectus from its insertion and hold it in a forceps. Medial rectus is a very strong muscle and has got a contractile property. So what will happen? You must be holding it in a forceps. Suddenly the muscle will just contract and slip out of your forceps and go sit at the orbital apex near the superior orbital fissure area, from where the muscle cannot be retrieved. You can take an MRI, you will see a globular structure sitting on the superior orbital fissure. Okay. So the patient had come to you for a small skin convergent skin just before her marriage to get corrected. Now you have made it a very large squint because the medial rectus is gone. Now you may have to face all the consequences of this. So the muscle which is lost in squint surgery is medial rectus. Many times asked question. This question had come as lost muscle in squint surgery, slipped muscle in squint surgery. Many ways this question had been asked. And so the strongest medial rectus, strongest extraocular muscle, medial rectus. So many times, so many other entrance questions from this area. So it is medial rectus, lost muscle or slipped muscles, or the surgeon's graveyard muscle in squint surgery, because probably you lost the medial rectus. The patient has come with a small skin, you have made it large skins, and patient bystanders may show you a graveyard. So probably that is why this muscle is appearing as lost muscle, slipped muscle, surgeon's graveyard muscle in squint surgery. So another common disease is Duane's retraction syndrome. Again, a difficult question which used to come for IMSS examination. You probably may not be knowing these conditions. Duane's retraction syndrome. So Duane's retraction syndrome, listen to me, is a limitation of abduction. It is a limitation of abduction. That means the it is just like lateral rectus palsy, limitation of abduction. If you look at this, lateral rectus cannot work. So what will be the position of what type of convergence, what type is the position of the eye? You may be thinking that the eye may be convergent because of the unopposed action of medial rectus. And the answer to this question is convergent squint. That is why this entrance question, again, that the position of the eye in Duane's retraction syndrome, as asked in the entrance question, it is not convergent squint. It is eye is straight. That position is called orthophoria or orthotropia. So that was again asked as an entrance question. Duane's retraction syndrome, the position of the eye is orthophoric, or the eye is straight. We are expecting a convergent squint, but that is not true. The position of the eye is orthophoria. So it's a limitation of abduction. That is the first thing. More common in females. So all congenital diseases are common in females for the reasons which are unknown to us. All congenital diseases are common in female, that too on the left side of the body. Medical science probably cannot explain this. So the answer you already got now, the right is more common. It's all congenital diseases are common left side of the body. This is a disease where there is co-innervation of the medial rectus with lateral rectus. What will happen is medial rectus is supplied by the third nerve, which also supplies the lateral rectus. Actually, lateral rectus is supplied by the sixth nerve, LR6. Here is a situation where medial rectus is supplied by third nerve, the same nerve supplies the lateral rectus. So when the medial rectus is put into action, lateral rectus also contracts and the eyeball retracts and the palpebral aperture narrows. So co-innervation of medial rectus, lateral rectus, eyeball contracts and the palpebral aperture narrows down. The medial rectus, which also supplies the nerve to medial rectus, third nerve, which also supplies the medial, also supplies the superior oblique and inferior oblique. So the superior oblique should be supplied by fourth nerve. Here the medial third nerve supplies which supplies the medial rectus, also supplies the superior oblique. So when the medial rectus put into action, the superior oblique or the inferior oblique comes into action. The eye not only adducts, eye also goes up and down. So the features of the Duane syndrome are limitation of abduction, the eye is orthophoric, there is co-contraction of the medial rectus, lateral rectus, so the eyeball retracts and the palpebral aperture narrows down, and the co-innervation of medial rectus, the lateral rectus, superior or inferior oblique. So when the eye adducts, the eye upshoots or downshoots. It is common in females on the left side of the body. This condition is called Duane's retraction syndrome, and the treatment of this is Faden operation, F-A-D-E-N. Again, another entrance question. F-A-Y-D-E-N, Faden operation. Another entrance question. F-A-Y-D-E-N, Faden operation. Okay. So this is Duane's retraction syndrome. This condition is associated with keratoconus, deafness, congenital lymphangiectasia, and the and clippal field anomaly. So this is associated with keratoconus, deafness, spina bifida, and clippal field anomaly. So this is Duane's retraction syndrome, another common. So many questions has been asked from Duane's retraction syndrome. So I think we are nearing time. I don't know about this. And so I have touched into the question that had come from retinal diseases, that had come from the area of strabismus. But there are so many other questions. I don't know. It's only up to 9 o'clock. I think I have no hesitation in leaving the 400. I mean the or 500 odd questions with you. I can actually send you the Word document of it to the IMA. From there, you can collect and study. They are actually the most frequently asked questions, or the prototype questions to help you to answer other questions.